Hello, my name is Dr. Bridget Scott, and I'm delighted to welcome you to this AstraZeneca-sponsored webinar, Changing Practices and the Impact of New Treatments in Multidisciplinary Cancer Care. Joining me today are two great speakers, Professor Hardev Panda and Professor Charlene Gill. Hardev Panda is Professor of Medical Oncology and Director of the Surrey Cancer Research Institute, University of Surrey, and Consultant in Medical Oncology, St Luke's Cancer Centre, Royal Surrey Hospital, Guildford, UK. He is a clinician scientist and urological oncologist who trained in internal medicine and medical oncology at Hammersmith Hospital and the Royal Marsden Hospital, London. Professor Panda completed his PhD at Imperial College in the CR labs. He was appointed Professor of Medical Oncology at the University of Surrey in 2007. Professor Panda has undertaken programs in scientific and clinical research in many aspects of immuno-oncology, targeted therapy, gene therapy, and oncolytic virotherapy, as well as leading human studies of targeted agents for the treatment of solid malignancies. Charlene Gill is Professor of Medicine at the University of British Columbia and a medical oncologist specialising in gastrointestinal malignancies at BC Cancer, Vancouver, Canada. She received a Bachelor of Science in Pharmacy and an MD from the University of British Columbia in 1996, followed by residencies in internal medicine and medical oncology. Professor Gill completed a fellowship in GI oncology at the Mayo Clinic and a Master's in Public Health from the Harvard School of Public Health. In 2017, she completed an MDA at the University of North Carolina. She is actively engaged in education and research with over 120 peer-reviewed publications and book chapters. Professor Gill is the chair of the Canadian Clinical Trials Group GI Disease Site Committee and chair of the UBC Department of Medicine Mentoring Committee. She is the editor-in-chief for Current Oncology and is the president of the Canadian Association of Medical Oncologists. Her TEDx talk in 2022 on how to flip the script on cancer delivered her passion for patient advocacy and empowerment. Following presentations by Professor Panda and Professor Gill, there will be a live Q&A session where you are invited to ask our experts any questions you may have on today's topic. Please type your questions in the questions section on the right and we'll try our best to answer them all. The views and opinions expressed are those of the speakers and not necessarily those of AstraZeneca or EMJ. Professor Panda will start off the webinar.
Changing practices and the impact of new treatment therapies in multidisciplinary teams. It's a great pleasure to participate in this discussion, and I'm going to start with my disclosures, which are as shown. The key question, certainly in the UK, is why do we have multidisciplinary teams and multidisciplinary team meetings? This all started very much with an appraisal of the poor standards of cancer care in the UK and the Kalman-Hein report publication in the mid-90s, through to NHS England equivalent in 2000 about really very much delivering the high-quality evidence-based cancer care versus a very sort of very personal perspective from many oncology centres. And rapidly, the MDTs have become the gold standard of cancer care in the UK. Remarkably, it is now 22 years since the big changes were first initiated. And I recall as a trainee, this was under great resistance by the oncology and surgical oncology fraternity in particular. And it was designed to address the discrepancy in quality of cancer care in different parts of the UK. Of course, we know in North America, the tumour boards have been active for more than 50 years. And what I think we tried to do was to incorporate very much a scientific, histological, radiological evaluation of patients combined with very much all the other components of patient care, including social and psychological issues, and try and come up with a recommendation of how the patient should be managed. And this is very important because I think over time, people have started to use the MDT in the UK as a sort of validation tool of some form of decision making by a committee. But of course, what it's designed is to give advice and guidance to clinicians as to how to manage patients. And the key changes over time have been reflective of more and more complex treatments and patients who are going on to second, third, fourth, fifth, and even sixth line treatment. The composition of MDTs, of course, is very dependent on local factors, the size of the cancer centre. We are delivering cancer care in smaller centres, in peripheral satellite units. And depending on how common or uncommon the disease one is managing, this can be looked at in a sort of local, central, regional, or a super specialist context. Interestingly, in my area, in urological oncology as an example, non-cancer specialities are also adopting this MDT approach. And the example I can give is stone management, urinary incontinence, reconstructive urology. So the demonstrated benefits, I think a lot of this is very still very controversial and for discussion as to exactly the benefits. But I think as a medical community treating cancer patients, it is absolutely beyond any shadow of doubt that it is best practice to have an MDT approach to optimally manage our patients and arguably optimally manage our resources and finances. There have genuinely been improved timelines to diagnosis, I think. There have been improvement in patient outcomes, and there are a very large number of studies which show this to be the case. It's also reflective of our sort of attitude towards healthcare professional well-being and also, of course, cost effectiveness in an era where more and more complex cancer treatments, targeted therapies, and expensive cancer medication, which is then given to patients over a very long period of time, is coming to sort of almost bring the National Health Service to its knees financially. And one has to sort of also ask, is the MDT actually nimble at adopting new treatment paradigms easily? This is all very well having these amazing developments in molecular diagnostics, etc. But are we in a position to get these into the MDT process and get them into the clinics to offer our patients? The keys to an effective MDT, of course, were asked. This question was asked almost at the beginning. Even within a year or two, we were looking at audits in the UK of how effective our MDT process as a new concept was becoming, and obviously the early data was extremely positive. We've now had some very formal and large-scale evaluations with stakeholder participation and the evolution of very much of evidence-based tools and stakeholder-driven algorithms. And the conclusion really is that in the context of exponentially increasing patient numbers due to the fact we have more and more cancer cases, and of course patients are doing better and better on multiple lines of treatment, we're having to look at this idea of streamlining during and after an MDT meeting, because there is just the burden of cases is just too huge. And there are a number of tools, and one of the interesting ones is, for example, this MEDIC, or measure of case discussion complexity, and the idea is shown on the cartoon on the right, that conventionally you have a new cancer diagnosis, which due to our national directive is referred to an MDT for discussion in an MDT context, and we take all cases, an MDT meeting happens, and an outcome is recommended. Now, the challenge to this is, of course, this is to reduce the numbers, and to streamline is to refer and sort of triage almost patients into pre-MDT context, and then really save the bulk of the time for complex case discussion and use pre-existing algorithms that have been decided and agreed for patients with more straightforward sort of diagnosis and management prospects, and therefore have much less delay. The challenges and barriers, of course, to MDTs, first and foremost, is the functioning across centres. And this is wide variations across the UK. And this is not just due to funding, it is due to the size of the centres, number of people in the room, literally. In some MDTs I've worked in, we don't have a pathologist. We have pathology reports. We don't see actual images on a screen of the histology. We just get a conclusion, which isn't quite right. Now, a lot of these issues have been addressed, certainly in the urological context, by a number of surveys. An important one that was this Get It Right First Time, GIRFT initiative, And this identified that really in the context of small renal cancer management and prostate cancer radical prostatectomies, there were a number of deficiencies sort of identified. And this was a combination of a number of things which I'm sure are familiar to many of the audience. And it is primarily around the poor input of information, and therefore quite reasonably rejection by an MDT because there is not information, and in fact it's not safe to make even a recommendation. So of course this case gets rediscussed and bounced to the next meeting, which then adds to the burden. And then sometimes if these cases are hurried through because of pressure of cases, then inappropriate inclusion and conclusions can be made. There's also a slightly evolving cultural sort of issue, I think, in MDTs, sometimes perhaps due to the lack of understanding of perhaps more junior members that what is the function of the MDT in terms of that recommendation process. The fear of actually making decisions outside the MDT. The MDT is not needed as a legal body and a rubber stamp to make clinical decisions. It is there to offer guidance towards management. And in the MDT room, I've personally witnessed, I'm sure we all have, examples of colleagues where they're out of their depth in terms of their knowledge. Communication isn't great in the team. People feel, although they have the ability and experience, they feel some degree of intimidation to come forward. And the overall result is, you know, a stressed, unbalanced group, which is dysfunctional, rather than everybody working in the more optimal way. And this is often further exacerbated by poor resources, excessive workloads, and of course poor sort of administrative support, all of which, to be fair, every NHS trust is trying their very best to address. So the evolution of the MDT model in an era of genomic medicine and the most exciting oncological advances, you know, of all time, you know, year after year with these amazing new drugs, is perhaps number one is obvious, which is we don't really need to discuss every single case. And the NHS England review in 2020 and the CR UK similarly have endorsed this, that actually simple cases are simple and straightforward. And the focus with the time available has to be on the complex cases. And as I mentioned earlier, the more straightforward cases following a predetermined, agreed sort of clinical algorithm. Most of the MDTs in the UK are very much based on surgical, with a surgical focus on surgical management, and then the oncological management goes alongside. And we haven't really got into the MDTs in terms of managing toxicity, in terms of our targeted therapies. So the solution has to be the idea of case selection, complex case prioritization, and this streamlining, and then just calling simple cases simple, going through these predetermined algorithms, and then using all our time to have the really more in-depth discussion we need to have. And obviously a continual audit of our practices, see if this is successful in terms of patient outcomes. The one area also that's come under discussion a number of times is to have this chairman's action type of context where the chair of the MDT has more powers to ask for reviews outside the MDT. Now this of course needs the MDT chair to be released from some clinical duties to actually action this process most efficiently, and to receive administrative support. And I think you know, the senior clinicians that would be involved in delivering this could actually improve what we have significantly within a very short space of time. We talked about in the title as effect of new treatments on the MDT, and I think in the urology context, I think one of the really most important studies in urological oncology to date has been the Stampede study, which is a really good case example for this discussion of MDTs, because this is a study that has been a landmark event in clinical trial design and has absolutely been embraced into the MDT context and process. And for those of you not aware, this is a study in prostate cancer, which is targeting men in 4 groups who would normally receive long-term androgen deprivation therapy. And as you see on the slide, these are high-risk localized disease, node-positive cancers, newly diagnosed metastatic disease, and those patients who are high risk after radical prostatectomy or external beam radiotherapy. Now, the traditional approach to all of our clinical trials is to do phase 1, 2, and 3 studies, and in common cancers such as prostate and breast cancer, you have a number of concurrent studies, and these are shown as trials 1 to 4. And as each trial moves from one phase to another, the next trial is sort of independently designed and executed. The idea of Stampede was to have a combined approach whereby we are testing a number of different drugs in a number of different contexts all at once, and that if it's quite obvious that a certain drug combination or is not working, then that arm of the study is dropped. I can demonstrate this in a little bit more detail on the next slide. So this is the Stampede study shown, and as you see in the green, you see the treatment combinations these patients will be randomized to. And this is a study that started, as you'll see, in 2006. So one of the earliest combinations was the addition of a bone strengthening agent, zoledronic acid, to standard of care. And this was an example of a combination that wasn't effective in extending survival and patient outcomes, and therefore was dropped and rejected. And subsequently, a number of other arms have been added. Some of them are still present, and some of them have proved ineffectual. This has actually resulted in the recommendation of a number of treatment combinations, including docetaxel and abiraterone. And as a result of upfront treatment with systemic treatment with chemotherapy or targeted therapy, has resulted in some of the most impressive patient survival outcomes ever recorded in oncology trials in metastatic patients. So what are the current research areas that will feature in MDT discussions? Now, this is quite a wide question, and one that's very difficult to answer because, of course, it all depends on the strategies being validated. So we know there's a very large number of risk algorithms, and in prostate cancer, there are numerous that are really good for stratifying patients for selection in specific arms of clinical trials. But to date, we don't use a single one really to determine our treatments. So no therapeutic decisions have been made on that basis. We know about the huge explosion in technology in identifying effective cancer biomarkers using blood, tumor tissue, urine, etc. But of course, up to now, there are very few that are absolutely standard of care. And on the whole, they lack the sensitivity and specificity for us to make MDT recommendations for directing patient treatment. We know we're coming close in terms of genomic data with blood and tumor tissue. And beyond just simple mutational analysis, we've got other broader tools such as mutational burden, the IO360 nanostring panel, which is also an interesting immune analysis. And of course, these are at the moment not used in a routine basis. And right around the corner is a huge international interest in the microbiome, which are intracellular bacteria, which are present in the gut and in the tumor, and which are directing the effectiveness or not of systemic cancer treatments. And I think the bacterial component of the gut is going to have huge influence in our choice of cancer treatments going forwards. And I think also this is going to be something to be discussed in the MDT context. But there are some interesting tools that can help maybe try and address some of this huge sort of burden of data that we have to deal with. And this is around this evolution of software for clinical decision support systems, including perhaps an overused term, artificial intelligence. And some examples in radiology, pathology, and genomics are certainly in the PIRAD score, which is MRI analysis for patients in assessing prostate cancer tumors. There are neural net type algorithms. There's histology. This page, prostate alpha, is an example, whole prostate whole mount slide imaging to try and increase diagnostic accuracy. And of course, we're all familiar with next generation sequencing with high throughput screening. The one issue that has been raised is the question of patient involvement in the MDT. And although this is clearly an aspirational and really a positive concept, the logistics of patient involvement at the early stage, I think, is going to be very difficult. And I think the fact that we have the discussions armed with an MDT recommendation and discussion prior actually will probably mean that, except in very exceptional cases, the patient involvement will very much be in the clinic rather than in the MDT, in my opinion. So the recommendations going forward is really to avoid bringing back patients. Now that is quite a significant burden, and that really reflects lack of preparation and lack of information quality to have a single meaningful discussion. So that's really important. The use of the stakeholder algorithms, as I discussed, and focusing on these complex cases, we need to be quite nimble in terms of new technology and adopting this. I think an enhanced role for the MDT chair could certainly be discussed at a higher level now. And I think this continual investment in the team development, because this is the core of the cancer networks. In the cancer networks, it is the MDT teams which are sort of leading the whole sort of patient management process. And I think we need to keep meticulous audits, and we need to review these at regular times, I think, to try and continue to improve what we have, which I think is an incredibly important tool and forum for managing our patients, having best practice and having best outcomes. Thank you.
So I'm delighted to speak to this topic about the importance of multidisciplinary cancer care and multidisciplinary cancer conferences. In the context of my experience, I'm a GI medical oncologist. I'm based out of BC Cancer in Vancouver, Canada. We are a tertiary referral center, and I think that this has kind of been an area where we are increasingly sort of understand. I would say the growth has been organic in our experience of the use of MDTs, but increasingly understanding the importance of trying to develop efficient and organized sort of models and actually a science around how best to conduct MDT. These are my disclosures. And Dr. Panda, it's already sort of laid the groundwork for this discussion. But we kind of remind ourselves of the reality that in many fields in medicine and oncology in particular, input is required from multiple disciplines, and we typically think about sort of the trimodalities of radiation oncology, medical oncology, and surgical oncology. But we know it's much more than that. And MDT support shared decision making across these multiple disciplines with the goal of improving patient outcomes and also improving treatment efficiency. Why is MDT review important? In no particular order, I think in my clinical practice, these are the reasons why I'm going to say I show up. These are the reasons why I make time in my busy practice to make sure I am present at MDT. We know that we are living in a really exciting time in oncology, but which has translated into sort of increasing case complexity, often as a consequence of a changing treatment landscape, which is one of the areas we're kind of focusing on our discussion today. MDTs can also be very helpful to identify patients for clinical trials, so that opportunity to review patients and see if they may be eligible for trials. When the evidence is less clear, so in the context of that changing treatment landscape, often we know that there are areas that are very gray in terms of what would be the sort of most strategic approach for treatment management, and MDTs really help facilitate and provide guidance for oncologists and treating physicians. There is an element of quality assurance. I think Dr. Panda spoke to that. In my practice, it's it's not a requirement, I would say, for case review, but it does allow for an opportunity to ensure that cases are being managed per clinical practice guidelines. We are an academic center, so we often have our trainees participate in our MDT, so there's tremendous educational value. And I will say not just for trainees, but also for those of us who have been doing this for a long time, to learn from our colleagues in different disciplines about sort of changing practices. And in Canada, which is also a publicly funded environment, oftentimes for certain treatment protocols, for funding approval, review at MDT is a requirement. So that is less common, but increasingly, I think, as we are offering more complex therapies for patients, this is also becoming sort of a goal of MDT. I'm going to be sort of a bit narrow, but to try to kind of, for illustrative purposes, sort of speak to my world of GI oncology. And all cases are potential candidates for review at MDT. We tend to focus, I would say, most of the cases that are reviewed at our MDTs tend to fall into one of these 6 buckets. And what they share in common is the fact that these are cancers that often require trimodality treatment. And these are cancers where the landscape of treatment has really changed significantly over the past decade, I would say. So hepatocellular cancers, stage 2, 3 rectal cancers, again, where there's a neoadjuvant approach, and that requires some planning up front and case selection for which approach is suitable for which patients. Oligometastatic colon cancer, resectable pancreatic cancer, again, is sort of a discussion about neoadjuvant approaches, definition of resectability, borderline resectable. Stage 2, 3 esophagogastric cancer, again, where we have many options in the neoadjuvant treatment that are multimodality, and increasingly advanced neuroendocrine tumors, where for us in GI, it's kind of our first application for theranostics. And so we have nuclear medicine participation to discuss, appropriateness of, systemic treatments, surgical treatments, and now, radionuclide-based treatments. I'm going to give an example of sort of a case, which is really, at face value, not complex, but you can kind of illustrate why we lean so heavily on MDT. So if we have a gentleman who's hepatitis B positive, has multifocal HCC, which is considered by Barcelona Clinic Liver Cancer Staging as intermediate stage, stage B. The options that may exist for that patient may range anywhere from resection to liver-directed therapy, whether it's chemoembolization or radioembolization. And there may be considerations for transplantation. And then there may also be now, with more efficacious systemic therapies, consideration for earlier use or upfront use of systemic therapy, and that whether it's immunotherapy or a TKI-based therapy. Other considerations in this patient when thinking about the treatment is also managing their underlying hepatic reserve and managing their, the fact that they're hepatitis B positive. And so that requires, as just you can see, an intersection of all these disciplines that are illustrated here. So interventional radiology, radiation oncology, surgery, hepatology, and medical oncology. And so this is a case that would often be brought forward for MDT for some guidance about what would be the most appropriate treatment approach for this patient. And again, coming back to this idea of changing treatment landscapes, I've been doing this for about 20 years now, and I used to think it was complicated, and it's more complicated in a good way for our patients, but really brings to bear sort of the importance of having an intentional, approach. So the treatment of HCC 10 years ago, again, thinking about this Barcelona Clinic Liver Cancer Staging algorithm, was fairly heavily based on, are they resectable or not? We had very limited options for systemic therapy. And so the discussions were not honestly that complicated. In 2022, we now have really an array of potential local regional options that are being considered for patients with earlier stage disease. And we've gone from 1 potential systemic therapy option to 8 potential systemic therapy options, including immunotherapy or TKI-based therapy. And this also migration of treatment across stages. And I can honestly tell you that many years ago, the presence of a medical oncologist was optional at a liver cancer MDT, and now it is critical for that voice in patient discussion. The same could be said for metastatic colorectal cancer. Again, I talked about sort of that as being an area where we, up until really quite recently, did not have much in terms of systemic therapy options for patients, a very linear approach. And we've gone from that to a very biomarker-driven approach a decade later, which speaks to the importance of really taking into factors that we didn't think about before in terms of molecular profiling and expectations in terms of the prognostic and predictive value of that information on top of the sort of conventional information we typically relied on. In my practice, we have I spend anywhere from 4 potentially to 6 hours a week. I could spend I'm committed to tumor boards that include a liver tumor board, which is a tumor board that's led, in fact, by our interventional radiologists, and participation across the multiple disciplines, and that's often where cases for HCC, colorectal, liver mets, and cholangiocarcinoma are reviewed. We do not review all cases in any of these tumor boards. It's very much focused on cases which have a complexity that requires multidisciplinary input. But as we know, over the years, that bar has become less and less. Most of our cases require multidisciplinary input. We have a pancreatic cancer tumor board. This is led by the hepatobiliary surgeons who chair the session, but it's focused really on patients with resectable pancreatic cancer, in focusing on imaging review, discussions about neoadjuvant treatment. We have a sort of a GI other tumor board, I will call, where most of the cases for patients with oligometastatic colorectal cancer, neuroendocrine tumors, esophageal gastric cancers are reviewed. This tumor board is led by medical and radiation oncology, and based on our capacity and and the kind of format we use, we're only able to manage about 6 cases per session, and currently this is once a week. I will add that we've now had kind of an offshoot of this as a separate tumor board on one of our early mornings for focusing on early stage rectal cancer. And that was really come out of the fact that in the last 2 years, the neoadjuvant approach for rectal cancer has changed sufficiently that it really requires most of our cases to be reviewed, and that volume can't be addressed in our current framework. And we also have a molecular tumor board. And this is a research based on a research platform at the BC Cancer Research Center, where patients who have undergone a molecular tumor board through our tumor review, through our personalized oncogenomics group, are reviewed with a focus on, what are the potential clinical trial options available for these patients. This is led by molecular pathology. This is a much more lengthy discussion, so the capacity for this tumor board is up to 4 cases per session, and this has now gone from once a week to twice a week. The typical format for most of these tumor boards is that the most responsible physician will present a case summary. That physician is also responsible for generating the conference note that will be part of the patient's chart. There is imaging and pathology review, and so we have a pathologist who will go through the slides and highlight relevant features of the imaging, of the pathology rather, and our radiology colleagues will, which is super critical function, will review all the imaging for us. And then there's a discussion and recommendation. And we have tried to pare down the discussion, really try to, more to try to support greater capacity. But we also don't want to compromise the value that comes out of that kind of a fulsome, discussion, particularly as these cases are more complex. So, where do we go from here? Like, this is, as I mentioned to you, in our center, this has been sort of, I would say, an organic evolution of how these conferences have emerged. Optimizing case selection, I think that really comes out of a recognition of how do we sustain the capacity to review cases. Greater participation of allied health professionals. So typically, and I think this is just because of the time burden that would be required and not having a framework for time to be protected, but we don't have nursing and pharmacy routinely present at our MDTs. We don't have psychosocial oncology typically present at our MDTs. And we know that those are also critical parts of patients' cancer journey. Sufficient administrative support and time. So we need, someone to be able to manage and organize these conferences for cases to be submitted. And each group has kind of figured out a way to do it in their, within their own context. But again, there isn't there isn't a consistent approach. I will say that, one of the challenges has been trying to articulate, what is the value of MDT to, organizations and how we can protect, time for people to be able to do this. And I think this would be something interesting because I'm sure it's different in different regions. Workload management. So my area is just one disease site, GI, and I am, committing sort of, I don't see myself being able to commit more than the 4 to 6 hours a week. What if I treated multiple disease sites? Breast has their own, GU has their own, lung has their own. How do we make this really tenable or possible for oncologists who may have varied practices? And that kind of speaks to accessibility and efficiency. Many of my colleagues will say that one of the silver linings of COVID, and I don't know if you will agree, was sort of a very rapid adoption of virtual MDTs. And even now, as restrictions are kind of being lifted and we are able to, meet, most of the tumor boards are chosen to continue on in a virtual format. You lose something from the lack of interpersonal contact, but it is much more efficient. I can tell you, I would be running around to get to different hospitals to attend MDT on top of the time present. And I think that's one example, but are there roles in which technology can enable greater accessibility and efficiency? And Dr. Panda also spoke to, tools to support the flow of MDT as well. I think we have a real need for key quality and performance indicators. How do we demonstrate the value of MDT? And it's one of those things that intuitively makes sense, and I think that's why we are all very committed to MDTs. But and there has been research trying to look at how do we measure, what metrics, both in terms of quality and in terms of performance, can be assessed. But it's very difficult to try to quantify how MDTs improve patient outcomes, to demonstrate that. And I think that's an area where, I think trying to standardize performance indicators may be helpful. And finally, maybe this is just a North American issue, but there are also some questions about, medical legal liability around MDT. What really is the function of the MDT, and as Dr. Panda also mentioned, it really serves as a guidance. It's not, at the end of the day, the ultimate treatment decision is between the treating physician and the patient. But it serves as a guidance for our perspective. We have standard language in our conference notes that tries to highlight that this really, the conference serves as in an advisory capacity only. But I think this is something that I think less of a real concern, more of a sort of a theoretical, practical concern that that some people have about the role of MDT. So I think as treatment landscapes are rapidly changing and oncology care is evolving, I think the role of MDT is more important now than ever before. And in addition to sort of the multidisciplinarity of cancer care, it really does help to support the delivery of evidence-based care consistent with, best available clinical practice guidelines. And I think from a sustainability perspective, and this is a challenge we're struggling with, is trying to optimize the efficiency of MDT without sacrificing the quality is really critical, as we're seeing patient volumes and case complexity increasing. And again, I look forward to the discussion around that as well. With that, I thank you very much for your attention, and look forward to the questions.
Thank you both for your fascinating presentations. Okay, first question for Hardev. You mentioned the importance of continuous audit of MDT practices. How is this best conducted?
I think it will always be in the context of the size of the MDT and obviously the capability in terms of staff. So at one end, it may be very, very simple outcomes, and at the more complex, sort of over a longer period of time, the outcomes may be more in context of real patient sort of factors such as progression-free survival, overall survival, sort of thing that we look at a clinical trial. But those would be the very end of the other spectrum. I think in terms of day-to-day, I think the bottom level of the audit is obviously the number of cases, the number of times patients have been, number of MDTs that case has been sort of presented at, number of times it's had a repeat sort of discussion unnecessarily. So I think we'd start off at the bottom end really, and just actually set the bar very low, and then just work up from there, because there's multiple facets of the MDT which will need this continuous monitoring and continuous improvement.
I see. So the sort of the first level would just be looking at repeat discussion of patients, and then the sort of increase the complexity of the auditing with the eventual goal of PFS OS as the very long term gain.
And again, those will be clearly against historical sort of series and other centres. And
yes.
if my patients with renal cancer, are looking as though there's a sort of a median survival, that's significant 6 months less than other centres. I mean, these sort of things come out fairly quickly. So I think the main thing is to have that audit process, and have the fact that you are auditing and you're going to work your way around different aspects of the MDT in time gives the group that feeling this is a dynamic, ongoing, organic process, and not just a one-off end of the year, let's have a quick look, and yes, it's okay, we're doing fine.
Yes, it's sort of keeping it regulated so everybody understands how it's doing, and perhaps where improvements are needed or where changes are needed.
Yes, and as Charlene was talking about, sort of more molecular based sort of information inputting into management, optimal management of patients. The audits perhaps once taking on new technology. Remember in melanoma clinics when BRAF testing became fairly standard in the NHS. That's clearly it was a very big sort of change for the UK, because we never had molecular markers in the clinic before. It's that sort of thing, after 12 months then, or 18 months or so, let's look at the how this were we getting the molecular diagnostic back in time? Was it delaying patient treatment? Was it there to was it effectively triaging patients into the right treatment, etc.? So
yeah, okay, so monitoring at all different stages of the patient's care to see if they are receiving the optimal care that can be provided. Yeah, fantastic. Okay, Charlene, you indicated that optimizing efficiency is critical as patient volumes and case complexity are ever increasing. How might this be achieved? I mean, clearly the discussion we just had about auditing is going to help with that. Have you got any other thoughts?
Yeah. So I feel like I'm more looking for answers rather than have the answer. I think one of the challenges is that MDT is something that's often cited, recommended, in oncologic patient management, and it's not unique to oncology. But we don't have a lot of data on what are minimum accepted standards for an MDT, what constitutes an MDT. We kind of quite literally say just bring the different disciplines together and discuss a case.
Yeah.
And so the efficiency piece is really important because, as you said, we're seeing more patients, and with the changing treatment landscape, that means increasing case complexity. I think what Hardev mentioned from looking at it in an iterative way and learning from our current MDT practices in terms of where can we trim the fat per se, where can we improve efficiency without compromising the quality and delivery of sort of guidance in MDT. Maybe an opportunity for shared learning with other centers. So even in this case, this is a really interesting discussion for me, and listening to Hardev's presentation, we both work in different geographies, and so I think there is an opportunity for shared learning. I think practically speaking, I think we're going to need help from technology, and this was sort of discussed in the presentations. I mentioned the use of virtual meeting platforms for MDT discussion to allow for greater accessibility. Software, we still have challenges where not all the necessary patient information is available at the time a case is being presented, and that really interrupts the case flow. And I'm kind of embarrassed to say, so we providers have to fill out a form of what sort of information you have, and most people are horrendous at filling out forms. So if we had technology or software that enabled to make sure that, okay, there's a checklist of this minimum requirement is required for information available, and maybe that would also capture if cases have been presented at other MDTs to avoid redundant presentations. And then finally, I think Hardev talked about this, clinical decision support systems, AI. How can are there cases currently being presented at MDT that potentially could be where guidance could be given, or we could accelerate it or optimize it with these clinical decision support systems? I think that's where we have to kind of look to.
So lots of areas for potential improvement. It sounds like liaising with clinicians from different countries or from different specialities could be a good learning process for both sides, perhaps. And also, it seems the key problem to start with, perhaps, is getting all that information into the MDT in the first place, having all the information available at the very first discussion of that patient. Hopefully, if some kind of software or AI could help with that situation, then perhaps there'll be less need for the repeat discussions if all the information is there in the first place. That could only improve the process, surely.
Yeah. And I think the one last thing I would say is that currently we don't typically protect the time of clinicians who may be involved in sharing MDTs. It's kind of sort of an expected part of practice, but I think that investment is important so that someone can actually thoughtfully look at their MDT processes or within that center or within that institution, and to help guide how we can improve efficiency.
Fantastic. Now we've got a great question from the audience here. In terms of outlay, resource expense, workload, and time in utilising this approach, what sort of impact do we see this having on financials and economic costs of healthcare in the short or long term of implementation? And do you see scope for MDT approaches to be adopted in other clinical disciplines? Hardev, do you want to tackle that one?
Sure.
It's a good question, isn't it?
Well, I think we've covered the non-cancer context in that we know both in urology, as I said, there are lots of non-cancer sort of urological MDTs, but I think the MDT approach in terms of other medical specialities, rheumatology certainly in our centre, and endocrinology are two that I know have these similar parallel meetings to ourselves. So I think there's no doubt the efficiency of having collation of the patient information and having the key clinicians and support staff all in one place at one time is sort of common sense. It's sort of what we tried to do in years gone by, but we didn't have an official framework to force it to happen, and obviously documentation before, during, and after. So I think that's a given now. I think that this is a very useful, clinically useful model. I think in terms of the first part of the question in terms of health economic issues, I mean, it's a difficult one in the sense that certainly in cancer, we don't have too many alternative sort of strategies to the same problem. And, you know, we don't have choice of antihypertensives, we don't have choices of different sort of head-to-head, one-to-one. In terms of what we are focusing on, for perhaps I can give you an example, is that in urological oncology, clearly, and in other cancers, the sort of stage 1, stage 2 disease, where this is very much a surgical problem or a surgical issue, and the oncological aspect of this on early stage, where it's very much unlikely to have neoadjuvant and adjuvant treatment, and this is going to be a surgical process. The surgeons can then quickly take those cases away and discuss the nuances of the partial nephrectomy, you know, which approach, and whether it's cryotherapy or, you know, it sort of doesn't matter to the average oncologist as long as it's dealt with. So I think that starts to impact on the sort of the time and the spend of all of the clinicians in the room, in the you know who just have no input. I mean, in another field, another example is management of cysts, in kidney cysts. You know, Bosniak 3 and 4, and particularly Bosniak 4, they have malignant potential. But it's a long way from Charlene and I's practice in terms of needing an oncologist to intervene. So I think part of the economy is the people, is the professionals' time type of oncology. The next thing is a little bit more complex when obviously you have multiple different modalities of treatment, and of course the example in urology is external beam radiotherapy with the massive resource implications of that versus a prostatectomy. And these economic models have been looked at many times, and that's something that the MDT perhaps could actually retain some objectivity in the discussion, because it's something that's normally hijacked by the surgeons in the UK, that actually if you don't have a prostatectomy, you've not been treated properly. But actually, you know, the evidence, it doesn't suggest that at all. And so I think those are the sort of scenarios that these are sort of scenarios where I think that use of health resources and the economics may make a difference.
Fantastic. Charlene, do you have a quick response for that question?
I think just maybe 2 comments. One is, you know, the comment about, you know, time efficiency. Also, you know, time is valuable, so the cost of time. So I think in the case selection in our group, what we have done is, you know, we used to have patients being presented where it's only a systemic therapy question. So you have, like, you know, surgeons and radiation oncologists kind of sitting there, but, you know, not really, you know, leveraging their expertise. And so we diverted, you know, those cases and said to an asynchronous, like a private chat email group among the systemic therapy group only, and said, look, if you have a question that's only single discipline, that's not something we want to bring forward to MDT. And so I think that, you know, but we took us a bit of time to recognize that. The other thing from a health economics perspective, I would just add is that in my experience, MDTs have been, more often than not, have been helpful in guiding avoidance of unnecessary therapies, or therapies that are unlikely to be beneficial, that not only save the patient, you know, unnecessary morbidity, but also save the system, you know, costs. And so, you know, many times patients with kind of quote unquote borderline resectable pancreatic cancer, where someone's really keen and motivated to do a Whipples and the patient really wants it, but, you know, the MDT discussion helps to provide clarity on the appropriateness of those kinds of decisions. And, you know, we're guilty in systemic therapy as well of the same. So I think it intuitively, you know, MDTs will, you know, add, you know, save systems money, save patients, again, unnecessary morbidity. And so if we could somehow quantify that so that the value of the MDT could then be recognized in a way that it could be, you know, supported, you know, more administrative support, you know, more support for the participants of MDT to be able to protect their time to be able to do this really important work.
Fantastic. Thank you both. That was a great Q&A discussion. Now I have one final question for our speakers. What is one key message that you would like our audience to take away with them from this webinar? Hardev, would you like to go first?
Okay. I would say that I think the evidence that we have that MDTs have left is very much best practice. So my message would be that to any of the clinicians that would participate is that this is your MDT. Every MDT is different, but take ownership, be a stakeholder, shape the MDT. If you feel whatever you feel would improve it, and to make it very personalized to your geography and the folks that you have in the room, whether it's small resources or large resources, just feel empowered to make the changes, and that over a long period of time will make it most successful and durable, I think.
Excellent. Charlene?
Yeah, I would sort of for listeners would just add that you know, if you're treating patients with cancer, treatments are complicated. You know, we're talking about treatment landscapes that are changing very quickly in relative terms to, you know, and so that, if anything, really further exemplifies the value of MDT and the importance of MDT. So I think we sometimes are concerned about sort of the time commitment, and instead the lens to look at it is how can we really optimize, you know, how we use the MDT as a really important resource. I think we've gone from it being a nice to have to a must have in the treatment of our patients.
Wonderful. Thank you, Professor Hardev Panda and Professor Charlene Gill, for a fascinating discussion of the changing practices and the impact of new treatments in multidisciplinary cancer care. Thank you also to our audience for joining us today and for asking such stimulating questions. Finally, thank you to AstraZeneca for sponsoring this webinar. If you enjoyed this webinar, please don't forget to check out our EMJ Reviews website, where you can find other webinars, articles, and podcasts. Until next time, take care and goodbye for now.